and just to pick up where we ended in part 1, remember, our repairs are based off of anatomic sites. So you can see here, I've highlighted the anatomic sites for code 12001. Scalp, neck, axilla, external genitalia, trunk, and/or extremities, including hands and feet. Then we need to know the complexity. In this case, it's simple because that's what it says, a simple repair of superficial wounds. And then we need to know how long it is. So we need to know anatomic site, complexity, and length. Remember, we can add up ones with the same complexity that fit under the same standalone code. We add up the length and pick one code. So if we have a 1.5 centimeter laceration on the scalp, that's simple, it's going to be 12001. But if we have a 1 centimeter simple wound of the scalp, and we have a 5 centimeter wound of the extremities that is also simple, we would then use 12002 because we would add the two together to get 6 centimeters. So again, keep this in mind. And I would suggest to highlight or underline your anatomic sites in these codes so that, again, this is what we're going to look for. All these codes are going to be for things like wound repairs. So the easiest way to look for them is to look under wound repair. Now, sometimes we need to do more than just close a wound. Okay, sometimes we need to actually stretch skin to cover what we call the defect. So the defect could be anything. It could have been a cyst removed, it could be cancer, it could be a growth on the inside or outside of the body. And so adjacent means directly next to it. So an adjacent tissue transfer or rearrangement is stretching the skin next to the defect area so that there isn't a gap without skin. So first things first, it tells us, for full thickness repair of lip or eyelid, see respective anatomical subsections. So again, if we're doing a full thickness repair of the lip, we're going to go to digestive. Full thickness repair of the eyelid, we're going to go to the ocular system surgery. So these codes, 14000 to 14302, are used for excision, including the lesion, and/or repair by adjacent tissue transfer, or, and then our guidelines continue at the top, or rearrangement like a Z-plasty, W-plasty, VY-plasty, rotation flap, random island flap, or advancement flap. So this is for when we have a larger defect. We're removing the defect, so we're removing the lesion, and then we're stretching the skin next to it. Okay, now the Z-plasty, the W-plasties, the VY-plasties, that's what the incision looks like when they're cutting it into the skin. And so again, surgeons know how to do these to make sure that there's enough skin for a defect area. So that's one of the biggest things we need to keep in mind is how are they describing the adjacent tissue transfer or rearrangement. Now, this is very important. The next paragraph tells us the skin graft necessary to close a secondary defect is considered an additional procedure. So again, this is just stretching and pulling the skin. If we need to get a graft, we're going to have to get that from the next section of integumentary codes. For purpose of code selection, the term defect includes the primary and secondary defect. The primary defect resulting from the excision and the secondary defect resulting from flap design to perform reconstruction are measured together to determine the code. So again, it's up to the doctor to tell us how large are both of these and then to make sure we get the amount of square centimeters. So again, this is by type of transfer rearrangement. This is an adjacent tissue transfer. It's on the trunk anatomic site, and then how large is it? So again, we need to have these little pieces of information. Always think, because of skin, we need to know direct anatomic site. We need to know how large something is or how long. Again, in this case, it's square centimeters, so it's going to be how large. And then we need to know specifically what are we doing. Are we doing a wound repair or an adjacent tissue transfer? Now, when we need more than just stretching the skin over an area, that's when we get to skin replacement surgery. So let's go over a couple of different things about skin replacement surgery. So, as they tell us, skin replacement surgery consists of surgical preparation and topical placement of an autograft, including tissue cultured autograft, or skin substitute graft like a homograft, an allograft, and xenograft. Now, first of all, we're going to have two parts. That's why I put needs at least two codes. One is for the surgical preparation. We have to prepare the site that's going to be receiving this graft. Then we need to know what type of graft are we using. An autograft comes from the patient themselves. A skin substitute graft comes from another person, which is a homograft or an allograft. And we also have what we call a xenograft that comes from a pig, because believe it or not, pig skin is the closest to ours because they have bristles, not fur. And then we have what we call the tissue cultured autografts, which are where we use someone's piece of skin tissue and we help grow that tissue over a period of time to continue using it for the patient. So that's the first thing that we always need to know. Two codes, one for the preparation of the site where the skin is going to, and the other for the type of graft we're using. It then tells us the graft is anchored using the individual's choice of fixation. When services are performed in the office, routine dressing supplies are not reported separately. So again, this is something where we're going to include all of the regular supplies. Now, one of the things you'll notice in this section is that it tells us 100 square centimeters or 1% of the body area of infants and children. So we use these codes for both infants and children and adults. The separation is 10 years. So over 10 years, it's by square centimeters. Under 10 years, it's by percentage, and that's when you go to code book page 95 and you look at the percentage of body area for things like burns. We can also use it for this section. So again, we have to keep in mind there's an age for this, but we use the same codes for children and adults. There's just a separation, for children and adults. Now it goes on to tell us the measurements apply to the size of the recipient area. Where is it going? Where is it going to be received? We always go to where it's going, not where it's coming from. And then they tell us that procedures involving the wrist and or ankle are reported with codes that include arm or leg in the descriptor. So again, where is something in relation? Because remember, skin is everywhere. So they're telling us wrist and ankle are part of arms and legs for these codes. Now, we have a couple of codes for surgical preparation. So let's read what this is. What are we doing? Surgical preparation codes 15002 to 15005 for skin replacement surgery that describes the initial services related to preparing a clean and viable wound surface for placement of an autograft, flap, skin substitute graft, or for negative pressure wound therapy. So again, we are preparing the area. And tells us, in all cases, appreciable non-viable tissue is removed to treat a burn, traumatic wound, or a necrotizing infection. The clean wound bed may also be created by an incisional release of a scar contracture, resulting in a surface defect from separation of tissue. So again, we always want to make sure it's clean. We always want to make sure that we take any dead tissue or infected tissue off the body. And if we have to make an incision to release a scar, that is also acceptable and all bundled in with these procedures. Okay. It then goes on to tell us in the first full paragraph, select the appropriate code from 15002 to 15005 based upon location and size of the resultant defect. For multiple wounds, sum the surface of all wounds from all anatomic sites that are grouped together in the same code descriptor. So again, same complexity, same area of the body, same code descriptor, we add them together, even for our skin substitute surgery. Then we have a couple of definitions. It tells us the autografts and tissue cultured autografts include the harvesting and or application of the autologous skin graft. Remember, auto means self. Repair to the donor site requiring skin graft or local flaps reported separately. Removal of current graft and or simple cleansing of the wound is included when performed. So again, that's all what's inclusive. It then reminds us that after we do where it's going to, we then select the appropriate code from 15040 to 15261 based upon the type of autograft and location and size of the defect. The measurements apply to the size of the recipient area. Again, where is it going, not where is it coming from. As I have my notation at the bottom. Always code to where the graft is going, which is the recipient area. So our skin substitute grafts include non-autologous human skin, which is dermal or epidermal, cellular or acellular grafts, like homografts and allografts that again come from other people, and non-human skin substitute grafts like xenografts that come from pigs, and biological products that form a sheet scaffolding for skin growth. That is a chemical component that acts like skin. And again, depending on what's wrong with the person, where you're working, is what type of graft you will use. So we're just going to go up a little bit. Okay, now a couple other things that we need to know about these codes. It tells us at the top, removal of current grafts or simple cleansing of the wound is included when performed. So cleansing is always included. Do not report 97602, okay, which is the debridement. That's a different type of debridement. Debridement is considered a separate procedure only when gross contamination requires prolonged cleansing, when appreciable amount of devitalized or contaminated tissue are removed, or when debridement is carried out separately without immediate primary closure. So again, debridement is always included unless it falls into one of those categories. Now again, for all these codes, for multiple wounds, sum up the surface area of all the wounds from the anatomic sites that are grouped together in the same code descriptors. Now again, the other thing to keep in mind is we add if under the same standalone code. That's when we can add these things together. So first we have, sorry, I didn't realize I was going to do that. Went back to the beginning here. So the first thing that we have to do is, again, we have to identify the anatomic site and see if the codes will fit underneath the same exact code. If they don't, then we're going to have to code them separately. So again, 15002 is a surgical preparation, trunk, arms, or legs. And then we have another standalone code 15004 for every other part of the body. And again, be careful, we have add-on codes for each additional 100 square centimeters. So if we did 200 square centimeters on the trunk, it would be 15002 and 15003. But if we did 300 square centimeters, it would be 15002 and 15003 times 2. We always want to make sure that we are capturing all of the amount that we're doing, because if we don't, then we're losing reimbursement. So again, all of this is going to be under the main term of skin grafts and flaps. Skin grafts and flaps. So those are the skin grafts. Now we come to the flaps themselves. And our flaps refer to skin and or deep tissues. So this can go much further into the body. Again, more for reconstruction. The regions listed refer to the recipient area, not the donor site, when a flap is being attached and a transfer to do a final site. So yet again, okay, where is it going, not where is it coming from. Now again, we have some updated guidelines. They're telling us that codes 15733 to 15738 are described by donor site of the muscle, myocutaneous, or fasciocutaneous flap. Okay, so again, still where is it going, not where is it coming from. They also remind us that these codes, 15570 to 15738, do not include extensive immobilization like plaster cast and immobilization devices. These are separate procedures and coded separately. And again, a repair of a donor site requiring a skin graft or local flap is considered an additional separate procedure. So again, we need to be careful about all of these. We could just be doing one, we could be doing multiple. If we're dealing with multiple skin grafts, multiple flaps, multiple wound repairs, we need to know everything that we're doing during that surgical session so that we make sure we get to the appropriate codes. And you can see here, again, we separate all of our different extremities for our flaps and grafts. Then specifically for code 15740, this describes a cutaneous flap that is transposed into a nearby but not immediately adjacent defect. Okay, and this is what we call a pedicle. So a pedicle is basically a think of like a sausage, okay? So the middle center is round and open. On each end, there's a blood supply. And we use these to reconstruct breasts, to add extra skin to an area because of a planned surgery, for reconstruction. And the idea is it's connected to the blood supply so it can keep growing, okay? And with the pedicle itself, it incorporates an anatomically named axial vessel into a design. So again, there is a vessel that's going to feed a blood supply to this skin. Now, the flap is typically transferred, as it tells us, through the tunnel underneath the skin and sutured into new position. The donor site is closed directly. So again, it's next door, but not directly next door. Not directly adjacent to the site. And again, usually we can tunnel underneath the skin for this. So again, the defect itself is much, much less. And you'll see a picture of this in the reconstructed breast in your textbook. Now, we also have what we call neurovascular pedicle procedure. So again, break down the term nerve, vascular, vessels. So these, again, they have nerves and vessels, are reported with code 15750. This code includes not only skin, but also a functional motor and or sensory nerve. The flap serves to reinnervate a damaged portion of the body dependent on touch or movement, like the thumb. So again, if someone loses the majority of skin on their thumb, they still have some touch sensation. Now, repair of donor sites requiring skin grafts or local flaps should be reported as additional procedures. Again, what's included in our code? Now, for random island flaps, VY subcutaneous flaps, advancement flaps, and other flaps from adjacent areas with that clearly defined anatomically named axial vessels, we go back to 14000 with 14302. Again, these are flaps and pedicles, so these always have at least a blood supply or a blood supply and a nerve with them, so we have to be careful. So again, skin grafts and flap. But what type of graft, what type of flap, and where is it going? So again, we have the island pedicle flap, we have the free muscle or myocutaneous flap, free flap with myovascular anastomosis. So again, we want to be careful. Now, after all of our skin grafts and flaps, we then get to our burn treatment. And again, these are local treatments only. If we need to do more than these treatments, we're going to have to go into other sections. So procedures 16000 to 16036 refer to the local treatment of the burn surface only. Codes 16020 to 16030 include the application of materials like dressings not described in the codes 15100 to 15278. List percentages of body surface involved and depth of burn. So that's what we need to know. We need to know the body surface, how much, and the depth of the burn, because that will tell us whether it's a first, second, or third degree burn. So again, first degree, again, initial treatment. So first degree is just a redness on the skin. Second degree, again, partial thickness. That's where you start seeing blisters. And again, they separate out the second degree into groups of percentages. And then down here, 16035 is an escharotomy. That's removal of dead tissue. Eschar is dead black tissue. And then again, it continues on into our third degrees as well. So again, you can look under burns for this, is the best main term. Now again, destruction procedures mean the tissue does not go to pathology. There is no living cells left in that tissue to look under the microscope at, so we don't do it. So they remind us that destruction means the ablation of benign, pre-malignant, or malignant tissue by any method, with or without curament, which is a scraping of the skin, including local anesthesia and not usually requiring closure. So again, local anesthesia, we could be using like a needle anesthesia underneath these areas. Any methods include electrosurgery, so using heat, cryosurgery, cold, laser, which could be hot or cold, and chemical treatments, again, to burn off these. Lesions include condylomata, papillomata, molluscum contagiosum, herpetic lesions or warts, like common warts, plantar warts, and flat warts, milia, which are deep-seated whiteheads, and other benign and pre-malignant, like actinic keratoses, or malignant lesions. So we got to be careful about these codes. So you'll see we have a lot of notations down here. 17000 is the first lesion. 17003 is for 2nd through 14 each. So if we are doing 10 lesions, we need 17000 and 17003 times 9. Otherwise, we will not get paid for it. We'll only get paid for 2. And if we look back up here, we use 17004 when we're doing more than 15 lesions in one session. So again, in this case, it's the procedure and the amount that we're removing in one session that depends on our codes. And for this, again, we can look under destruction. And then what type of lesion? Is it benign, pre-malignant, or malignant? Now, to go along with this is what we call Mohs micrographic surgery. Mohs surgery is used for most skin cancers because skin cancers are kind of like icebergs. You see a little bit at the top, but the majority is at the bottom, and it spreads very, very widely. So Mohs micrographic surgery is a technique for the removal of complex or ill-defined skin cancers with histologic examinations of 100% of the surgical margins, okay? It requires the integration of an individual functioning in 2 separate and distinct capacities, surgeon and pathologist. So what this usually means is the patient is either on the table or possibly with local anesthesia, and the surgeon is removing pieces of tissue in a ring that's going down into the skin. And for each piece of tissue they remove and look under the microscope, what they're really looking for is the margins, okay? They want to find non-cancerous tissue around the margins. So they go as deep as they need to go, and each one of these is considered a tissue block. Each time they go in and remove a little bit more tissue, this becomes a new tissue block, but it has to be one person doing these, one. 2 different people are doing that, that is not Mohs surgery. Now, the Mohs surgeon removes the tumor tissue and maps and divides the tumor specimen into pieces, and each piece is embedded into an individual tissue block for histopathologic examination. Thus, a tissue block in Mohs surgery is defined as an individual tissue piece embedded in a mounting medium for sectioning. So again, they remove a piece, and then they're going to slice it so it can fit under the microscope on a slide. That is one tissue block. So what we need to know is how many tissue blocks are we really dealing with? Okay, because when it comes to the codes, they are separated out by how many blocks that we're doing, okay, and also anatomic site. Now, the last section in integumentary is the breast. Keep in mind, when we're talking about anatomy and physiology, the breasts are considered part of the integumentary system since they're mostly made up of fatty tissue. They are only considered part of the female reproductive system when the woman is pregnant or has recently been pregnant. Otherwise, they're always considered part of the integumentary system. So, first thing that we're going to see here is excisions. So again, we could be excising a cyst, a calcification, a benign lesion, a malignant lesion. Regardless, what we need to know is the approach. Are they going percutaneously with a large needle, or are they doing an open where they're slicing and dicing? So, excisional breast surgery includes certain biopsy procedures, the removal of cysts or other benign or malignant tumors or lesions, and the surgical treatment of breast and chest wall malignancies. Biopsy procedures may be percutaneous or open, and they may involve the removal of differing amounts of tissues. We also use what we call localization devices. Localization devices tend to be little pieces of wire that they can stick into the skin, and they put the tip of the wire into the lesion. So when that patient goes under surgery, the doctor doing the surgery just needs to put what we call fluoroscopy or x-ray above the patient, and they can see directly where that lesion is. Because again, a lesion and a calcification look exactly the same under x-ray. But if we know the difference, that's when they're going to put the localization device in. The biggest part is what type of image guidance are they using? They can use ultrasound, MRI, CAT scan. They can also use what we call stereotactic. And then we also need to know, is it one breast or is it two breasts? This is when we're going to break out the LTs and RTs. For skin in general, we do not use modifiers LT, RT, or modifier 50 for left, right, and bilateral. We do for the breasts, though. So again, tells us when more than one biopsy or localization device placement is performed using the same imaging modality, use an add-on code whether the additional service is on the same or contralateral breast. Because again, this could be two growths in the right breast or one in the right and one in the left. So regardless, we have add-on codes for these. Okay. And so again, we have everything from excision of the chest walls, and then going into all the different image guidance procedures. Now, they tell us breast biopsies without image guidance are reported with the first codes that come in this section, 19100 and 19101. However, image-guided breast biopsies, including the placement of a localization device when performed, are used with 19081 to 19086. So again, if we're just going in and biopsying something, that's going to be from the first part. If we're going in and biopsying something and then we are putting in a localization device, that's going to be from this next set, the 19081 to 19086. It goes on to tell us, again, when more than one breast localization device placement is performed using the same image modality, use the add-on code whether the additional service is the same or contralateral breast. So again, doesn't matter how many of these we're doing. What we need to know is how are we doing it. So we have mammographic guidance. Again, we have ultrasound guidance, CAT scan guidance, MRI guidance, stereotactic guidance. They're all part of the guidance. Now, once we've actually identified the lesion or what may or may not be a tumor, that's when we're going to start going into some further surgeries. So if it is cancerous, that's when we might start doing mastectomies. Now we have partial mastectomies and we have total mastectomies. So partial mastectomies are when we're only removing some of the breast tissue, not all of it, not the majority of it, but some of it. A total mastectomy is we're removing the entire breast and surrounding tissue. So it tells us partial mastectomy procedures are reported using codes 19301 or 19302 as appropriate. Documentation for partial mastectomy procedures include attention to the removal of adequate surgical margins surrounding the breast mass or lesion. Intraoperative placement of clips is not separately reported. So sometimes we put clips in if it is cancerous so that we know where the radiation beam should go. However, total mastectomies include a simple mastectomy, complete mastectomy, subcutaneous mastectomy, modified radical mastectomy, and more extended procedures like the urban type operation. Total mastectomy procedures are reported using codes 19303 to 19307. Again, intraoperative placement of clips is not separately reported. So again, we can't code them separately. We can place them at the same time. So for these, again, we always want to look under mastectomy. Now what you'll notice is code 19300 is for gynecomastia, which is male breast growth. So again, this can be very embarrassing. And what happens is usually around puberty, the male breasts start to grow just like female breasts do. Of course, they don't have the same functional capacity, but it is something that could be embarrassing and may need to be removed. The other ones, again, how much are we removing out of the breast? So again, we've got our partial versus our simple complete versus our subcutaneous versus our radical. And again, remember the word radical, and this goes for the entire surgical code book. We're always removing surrounding tissue and lymph nodes. In this case, it's pectoral muscles and axillary lymph nodes. So if you're looking for a mastectomy, the easiest way to look under is mastectomy. For most of these other procedures, the main term of breast is always a good one, or the type of surgery like a repair, and then the word breast. All right, guys. So remember, integumentary is only difficult if you do not make your notations. So break out your highlighters, break out your colored pencils, your colored pens, and look at all the different sections of this so that you know best how to find the codes that you're looking for. Have a great day.